So what I'd like to do is to briefly summarize state of the art and to address some ongoing question and maybe perspective for the next few years. So you all know that we have seen a major improvement in the outcome of patients with multiple myeloma in the last 15 years, mostly because of the introduction of new drugs, the first generation with thalidomide, lenalidomide, and bortezomib, the second generation with two other proteasome inhibitors, carfilzomib and ixazomib, a new IMiD, pomalidomide, and especially antibodies, an anti-SLAMS FSET antibody, elotuzumab, but two anti-CD38 antibody, daratumumab. And I do think that the reason why we have so much improved is because we now know that we have to combine all these agents and we have to give them for a prolonged period of time. So I start with the management of transplant-eligible patients. Autologous transplantation has been introduced in the 90s, and it remains the standard of care, especially in Europe, because of two randomized trials which compared intensive treatment and the best non-intensive treatment. And these trials were from Italy, here, plus Europe, and France. This one compared after induction with Velcade, cyclophosphamide, dexamethasone, either autologous transplantation or a good consolidation with Velcade, melphalan, prednisone. And the French one, after an induction with Revlimid or lenalidomide, Velcade, dexamethasone, 3 courses, compared autologous transplantation plus 2 courses of consolidation and 5 more courses of Revlimid, Velcade, dexamethasone. And the results were the same, significant benefit in terms of progression-free survival for the intensive arm. So currently, the design of the treatment of transplant-eligible patients is the following. First, we start with an induction therapy, 3 to 4 cycles with new agent, with the objective of reducing the tumor burden and cleaning the marrow before stem cell collection. Then we have hydrotherapy and autologous transplantation, a consolidation of 2 to 3 cycles identical to the induction therapy, like in the leukemia treatment. And we have, after that, maintenance, mostly with lenalidomide or with bortezomib. The objective of this treatment is to achieve complete response and to maintain complete remission. And maintenance treatment is very important for this objective. I would like to discuss rapidly the induction therapy. What is the best? We now know that we have to use bortezomib in the induction treatment because it's better for high-risk patients. And this study showed that, This study showed that bortezomib-containing regimen are better than induction without bortezomib. So what is the best partner for bortezomib or Velcade? We have currently 3 combinations, and we now know that 3-drug combination is superior to 2 drugs. So these combinations are Velcade, thalidomide, dexamethasone, Velcade, Revlimid, dexamethasone, or Velcade, cyclophosphamide, dexamethasone. There are very few randomized studies comparing this combination. There is only one actually comparing VTD and VCD, and there is also case match analysis comparing VTD and VCD, and you see that the response rate, very good partial remission rate, is superior with VCD, although the toxicity and especially the peripheral neuropathy rate is increased with this combination. As regards the combination VRd, which is supposed to be better than VTD, we have no randomized trial, but the Spanish group performed an integrated analysis comparing their result with 6 cycles of VTD and 6 cycles of VRd, and you see that VRd appears to be better and is well tolerated. So VRd could be the best induction treatment. What about consolidation? We have two large randomized studies addressing the question of consolidation after autologous transplantation. This is the US trial where patients, when randomized after autologous transplantation, between a second course of autologous transplantation, a consolidation with 4 cycles of VRd, and no consolidation, and all patients did receive lenalidomide maintenance. Here is a European trial. I told you that they use VCD induction after VCD induction randomization between autologous transplantation and non-intensive treatment. And there was a second randomization between consolidation with 2 cycles and no consolidation. The problem is that the US study shows no benefit of any type of consolidation, while the European study shows a benefit of consolidation with 2 cycles of VRd. I do think that it is because of a different induction treatment, and I will explain that in a moment. The question of single versus double autologous transplantation. Again, the European study shows a benefit for autologous transplantation, and this is in the same line as a retrospective analysis performed by Dr. Michele Cavo, showing that double transplantation is superior to single autologous transplantation, but mostly for high-risk patients, either international staging system 3 or high-risk cytogenetics. But on the contrary, as I just said, the US study showed no benefit of double autologous transplantation, even in the group of high-risk patients. Things are easier for lenalidomide since we have now 4 randomized trials comparing lenalidomide maintenance at low dose versus no maintenance. And you see on this slide that all 4 trials show a dramatic improvement of progression-free survival with lenalidomide maintenance compared to no maintenance. And what is even more important is that this improvement in progression-free survival translates into an overall survival benefit. But you see on this slide that we have to wait for at least 5 years before showing this difference in overall survival because of the efficacy of salvage treatment. So currently, lenalidomide maintenance is approved both by FDA and EMA. One important finding of all these trials in the last 5 years is that MRD negativity is a major prognostic factor in the transplant paradigm. And this has been shown by the Spanish group and shown by my group, the IFM, especially in the IFM 2009 trial. I'll just show you the design. When using flow cytometry at a level of sensitivity of 10 to the minus 4, you see a dramatic improvement of the progression-free survival and even overall survival for patients achieving MRD negativity compared to patients with MRD positivity. An important finding from my group, and especially from Hervé Harousseau, is that sensitivity matters. And the best level currently is a level of 10 to the minus 6. And when using next generation sequencing, Hervé Harousseau was able to show that there is a dramatic improvement of the progression-free survival and actually also overall survival in patients achieving this level of MRD negativity. So we have still some questions. The first question is induction, how many cycles? And I will explain why. Second question, can you improve the results with another proteasome inhibitors other than bortezomib? Is 4 better than 3? Which is the best maintenance? And we have new options. And the most important one, what will be the place of autologous transplantation in the future, given the current result and the hopes we have for the future? The first question, number of cycles. The Spanish group look at the impact of 6 cycles of either VTD or VCD, and you see here that the VGPR rate increased gradually from cycle 3 to cycle 6. When comparing the French result with 3 cycles of VRd and Spanish result with 6 cycles of VRd, you see here that the VGPR rate is much better with 6 cycles. But when looking at the final result after 2 courses of consolidation with the same VRd, you see that there is no difference. Meaning that if you have a longer induction treatment, you don't need a consolidation. And this is confirmed by the MRD negativity level in the Spanish trial. There is no improvement of the MRD negativity incidence after consolidation compared to after autologous transplantation. So that could explain why there is a difference between the US and the European result regarding the role of consolidation is simply because the American give a longer induction treatment with VRd, while the European give a short induction with a suboptimal treatment with VCD. If you have a good induction treatment, then you probably don't need a consolidation. Second question, carfilzomib versus bortezomib. We have no available randomized comparison, but there is an interesting trial which was shown at the last ASH meeting by Francesca Gay from Italy, comparing an autologous transplantation arm with an induction with carfilzomib, cyclophosphamide, dexamethasone, the same for consolidation, 4 courses each. KRD, carfilzomib, Revlimid, dexamethasone, induction and consolidation, and I will discuss that later, 12 cycles of KRD. And when you compare the result achieved with 8 cycles of KRD compared to 8 cycles of VRd in the Spanish trial, or only 5 cycles in the French trial, you see that the VGPR rate after consolidation appears to be better with KRD. So carfilzomib at a dose of 36 milligrams square meter could be better than bortezomib. Third question, the addition of a fourth agent to the current triplets, and especially the anti-CD38 antibody daratumumab. And we currently have experience with 2 approaches, the combination of DARA plus VTD and the combination of daratumumab plus VRd. These trials are not finished, but we don't have yet the final results. But we do have the result of this trial called the Cassiopea Trial, which were published recently by Philip Moreau in the Lancet. And you see on this slide that the addition of daratumumab does increase the CR rate and CR plus stringent CR rate from 26% with VTD to almost 40%. The same is true from MRD negativity, which is increased by the addition of daratumumab. This translates into longer progression-free survival, although the follow-up is still short, that you see that the difference is already significant. So the new treatment for autologous transplantation, induction and consolidation, might be a quadruple combination with daratumumab plus VTD or maybe VRd. The next question is maintenance. For many years, we have discussed the optimal duration. Until now, it's until progression, but maybe it's enough to give 2 years of maintenance treatment. It's better tolerated, of course, and even more important, it's less expensive. There is a question regarding high-risk patients, and there are conflicting results between the meta-analysis, I showed the result, and the British experience. So we have maybe to work on the high-risk patients, and maybe in the future we will use other agents, especially for patients with high risk, maybe ixazomib, which is an oral proteasome inhibitor, or daratumumab. And the final and maybe most important question is the place of autologous transplantation. Is it early in frontline treatment or delayed in relapse treatment? Why do we ask this question? Because in the European trial and the French trial I showed initially, there is a progression-free survival benefit, but no overall survival survival benefit as shown here. And I showed you the 40 trial reported by Francesca Gay at the ASCT meeting. There was an arm with 12 cycles of KRD compared to autologous transplantation plus 8 cycles of KRD or KCD. And you see here that the preliminary result shows that the VGPR rate is the same when comparing 8 cycle of KRD or 12 cycle of KRD without transplantation. And when looking at minimal residual disease with transplantation or with 12 cycle of KRD, no difference. So in the future, maybe non-intensive therapy will be even better than now and could be preferred to autologous transplantation up front. My personal feeling is that autologous transplantation could be offered maybe only to high-risk patients. Now, the management of transplant non-eligible patients, mostly elderly patients. Currently, we have 2 standards in Europe, the Velcade melphalan which was published 10 years ago and which remain used in many countries in Europe. And the other one, which was published by the Thierry Facon and his co-workers, the first trial comparing Revlimid dexamethasone, low-dose dexamethasone, 18 months versus Revlimid dexamethasone continuously, and melphalan thalidomide, which was at that time the standard of care. I think that many of you know the results. Significant benefit in terms of event-free survival for Revlimid low-dose dexamethasone continuous, but no difference between the limited time, limited duration of Revlimid dexamethasone and continuous therapy. In the United States, there is another standard, which is a triple combination Velcade Revlimid low-dose dexamethasone, based on the result of a SWOG trial published by Brian Dury. This was for all age, but a large proportion of patients were over the age of 65. This is the superiority of VRD compared to RD in terms of progression-free survival and overall survival. And this was true even for very old patients, where the median PFS with VRD was 39 months compared to 20 months with Revlimid dexamethasone. But things are changing again with the addition of daratumumab. And we now have 2 trials to address the question of the interest of adding daratumumab to the standard of care, either VMP, the Halcyon trial, or Revlimid dexamethasone continuously, the Maya trial. Here are the design. You see here that in the Maya trial, half of the patients had a maintenance treatment with daratumumab. Here, it was a more simple comparison of DARA Revdex versus Revdex. And the results are the same. The addition of daratumumab did increase the response rate, shown here, and the minimal residual disease negativity here, that is the Halcyon trial, daratumumab plus VMP versus VMP. And in the Maya trial, approximately the same results in terms of response, complete response and better, and in terms of minimal residual disease negativity. This translates into longer progression-free survival in the arm with daratumumab. Here, the Halcyon trial. Here, the Maya trial. You see that at 30 months, PFS with DARA Revdex is 71%, while with the DARA VMP, it's only 60%. But it's maybe due to the fact that only half of the patients received maintenance in the Halcyon. So we have to wait for further analysis. An important question regarding the treatment of elderly patients is of frailty. We now know that it's not possible to treat all elderly patients the same way. And it was nicely shown by Thierry Facon in a sub-analysis of the first trial, looking at a simple assessment of frailty with only 3 parameters: the age, the comorbidity, and the ECOG level. And this allowed score system dividing the patient into frail and not frail. Binary system, very simple. And you see the striking difference in terms of progression-free survival and even more importantly, overall survival between the frail and non-frail. That means that we have to treat the frail patient in a different way. And one possibility is this so-called RVD light with reduced doses of lenalidomide, which was published in the British Journal of Hematology last year, and which provided very interesting results in elderly patients. You see here a median progression-free survival of 35 months. I finished with the management of relapsed multiple myeloma. Currently, we do have all these drugs for treating relapsed multiple myeloma, the initial new agent and the second generation new agent, which give us many possibilities. And the first one is a double combination of carfilzomib plus low-dose dexamethasone, which was compared to bortezomib low-dose dexamethasone. You can imagine that before the introduction of the second generation agent, the standard of care for relapse treatment were either bortezomib low-dose dexamethasone or lenalidomide low-dose dexamethasone. So the first comparison was this Endeavor study, which used a special dose of carfilzomib, 56 milligram per square meter, twice weekly, which were compared to the usual dose of Velcade. And you see a striking difference in terms of progression-free survival and overall survival. And it was even more true in patients who did receive prior bortezomib treatment, who remained sensitive to bortezomib, but who were already treated with bortezomib. Other possibility is to test this second generation new agent in addition to the standard of care, Revlimid dexamethasone or bortezomib dexamethasone. And these are the triple combinations which were studied. And we have here 4 randomized trials comparing Revlimid dexamethasone to the same combination plus a new agent, either ixazomib here, elotuzumab, carfilzomib, and finally daratumumab. And although we cannot compare trials, make cross-trials comparison, you see that the best is apparently the combination with daratumumab, since the ASCT ratio is fantastic at 0.37. Regarding bortezomib dex, we have 3 randomized comparisons, one with an HDAC inhibitor, Panorama 1 trial, one with daratumumab, and one which was recently published by Paul Richardson in the Lancet Oncology with pomalidomide. All 3 trials showed a benefit of the triple combination compared to the double combination, but again, the combination with daratumumab appeared to be the best with the ASCT ratio of 0.39. So we can conclude that all triple combinations are superior to double combination, and that daratumumab seems to be a breakthrough in the treatment of multiple myeloma. And especially because with daratumumab, we were able to demonstrate for the first time that it's possible to achieve MRD negativity in relapsed multiple myeloma. And these are sub-analyses of the Pollux trial, daratumumab Revlimid dex, and the Castor trial, daratumumab Velcade dex, and you see that it's possible to achieve MRD negativity at the level of 10 to the minus 5 or even 10 to the minus 6. And as usual, patients achieving MRD negativity, whatever the treatment they receive, had a much better outcome than patients with MRD positivity, even in the relapse setting. One problem with daratumumab is that it's given intravenously with a long infusion to decrease the incidence of infusion-related reaction, and very recently, there was it's not 2018, it's 2019, it was recently published, the comparison of daratumumab sub-Q and daratumumab IV. Um, the efficacy was the same, but there were less infusion-related reaction with the sub-Q administration. And of course, the sub-Q was much more convenient since the duration of sub-Q injection was 5 minutes, while the duration of IV infusion was 421 minutes for the first and 205 minutes for the subsequent infusion. So probably in the future, DARA sub-Q will replace DARA IV. So we have many more possibilities. I focus on the possibility in combination with the standard of care, Velcade Dex or Revlimid Dex. But you see here the number of possibilities we have with pomalidomide, with daratumumab, with elotuzumab, and with a new anti-CD38 antibody, isatuximab. I just show you the results of the IACH trial, which were recently presented by Prof. Richardson at the last ASCO meeting. This trial compared in patients with 2 or more prior lines of treatment the pomalidomide dexamethasone combination or a triple combination, pomalidomide dexamethasone plus isatuximab. And again, the triple combination yielded a much higher response rate and especially a much higher VGPR rate of 32% compared to only 8% with the pomalidomide dexamethasone doublet. And this translates into a much longer progression-free survival, 11 months versus 6 months. And what is interesting is that this triple combination is better than pomalidomide dex in patients who are refractory to lenalidomide and also in patients who are refractory to lenalidomide given at the immediate last line. So it could be a solution for lenalidomide refractory patients. So we have many combinations. How can we choose? Actually, it's not easy because there are many factors which can impact the results of the treatment. We have factors which are related to the disease, of course, the initial prognostic factor, the interval since last therapy, the aggressiveness of the relapse, the number of relapses. We have also factors related to previous treatment, and in particular, lenalidomide or bortezomib refractoriness, which is a very important parameters for predicting the success of a salvage treatment. We also have factors related to the patient, the age, the comorbidities, the performance status. And unfortunately, in many countries, we have the treatment availability because all these combinations are very expensive, and in many countries, they are not affordable. In my opinion, the most important factors to consider when deciding a salvage treatment are the age and performance status, and you cannot use a very aggressive treatment in elderly patients. And you have the lenalidomide or bortezomib refractoriness. So before deciding, you have to know what is your objective. In elderly patients, the objective is to achieve the best possible result, but without taking risks of toxicity. In advanced disease, if possible, clinical trial, and in end-stage patients, we should look mostly at quality of life. Which is more difficult is for patients in second or third relapse, you have to use drugs which have not been used earlier, or you have to include the patient into a clinical trial. But I would like to finish by focusing on first relapse, because in my opinion, in first relapse, in second-line treatment, we have to find the best treatment in order to achieve the best possible response rate and progression-free survival. And why is it so? It's so because we have known for a long time that the first relapse is the longest. The duration of response, the first response in first relapse is the longest. The duration of response decreases when you increase the number of lines of treatment. But another important finding comes from a real-life analysis, which was published in 2016, showing that the proportion of patients actually receiving salvage treatment decreases at each step of the myeloma treatment. For instance, here in second line, only 61% of patients do receive treatment, and in third line, only 38%. So you have to give the best treatment for the first relapse. Otherwise, maybe the patient will never receive this good treatment. So which is the best treatment for first relapse? We have some data based on the comparison of 3 agents versus 2, the ASPIRE trial with carfilzomib, the tourmaline trial with ixazomib, and the POLLUX trial with daratumumab in patients who are lenalidomide sensitive or lenalidomide naive. And you see again that apparently the best is the combination of daratumumab plus Revlimid dexamethasone. In patients who are lenalidomide exposed or lenalidomide refractory, you cannot use lenalidomide, so you can use Velcade, and this is the example of the CASTOR trial with daratumumab plus Velcade dexamethasone, which is dramatically superior to Velcade dexamethasone, or the Optimism trial, which compared pomalidomide, Velcade dex, and Velcade dex, and which yielded an interesting progression-free survival, median progression-free survival of 21 months. So I'd like to show this cartoon, which is an approach of the ideal treatment for first relapse. If you suppose that all drugs are available, in patients who are not refractory to lenalidomide, the best treatment might be daratumumab, Revlimid dex, according to the POLLUX trial. But there are many alternatives without daratumumab, VRd or another proteasome inhibitor, KRd or IRd, elotuzumab RD, and even the Endeavor study. In patients who are refractory to lenalidomide, you have daratumumab Velcade dex, which is apparently the best one, but you can also use pomalidomide Velcade dex, daratumumab pomalidomide dexamethasone, or isatuximab pomalidomide dexamethasone. So maybe many combinations, and you have to decide according the available drug. My last slide is again this one, showing the third generation of new agent. Because one of the problems of the second generation, and especially the daratumumab and isatuximab anti-CD38, is that they already moved to the frontline treatment. So in the future, we will have patients who will be refractory to lenalidomide, to bortezomib, and to daratumumab. So what will be the possibility? Well, we have some new agents which appear to be very attractive. We have, for instance, selinexor, which was recently approved by the FDA, and there is a nice paper recently published in the New England Journal of Medicine. We have venetoclax, which is active also in multiple myeloma, and which is maybe the first targeted therapy in myeloma, since it's active mostly in patients with translocation 11-14. And I believe, like the previous speaker, in new immunotherapy, Mohammed developed the CAR T cells in multiple myeloma. So it's a great hope, although we have still to learn because we have a high response rate, but responses are often short-lived. But we also have the antibody targeting a new antigen like CAR T cells, which is a BCMA antigen. We have bispecific T-cell engager, anti-BCMA, and we have also antibody drug conjugates. We have many possibilities, which are, of course, currently evaluated, but with new hopes for the future. So I'd like to conclude by saying that the successive introduction of new molecules has generated considerable progress in the management of multiple myeloma and considerable improvement of progression-free survival and overall survival. Combination, and especially triple combination and prolonged therapy, are the drivers of upfront treatment improvement. As I showed you, MRD negativity is becoming a new endpoint of multiple myeloma treatment. Until now, it was CR achievement. Now it's MRD negativity achievement. We have more and more solutions for multiple myeloma relapse, and we know that they contribute to the overall survival improvements. And finally, I do think that the use of anti-CD38 antibodies, daratumumab or isatuximab, in the frontline treatment will further improve the depth and the duration of first response, and will further improve the prognosis in multiple myeloma. With that, I stop and I thank you for your attention.